Okay, Dr. Sunil, we are live.
Good afternoon, my fellow healthcare providers, to nephrologists, physicians, dietitians, and nursing staff who all have joined this webinar. I, Dr. Sunil, medical advisor with Fresenius Kabi India, warm welcome you all. I am glad that all of you are committed for preventive, conservative, and curative treatment of kidney diseases. More than 10% of population worldwide is affected by kidney diseases, and millions die each year because of poor healthcare facilities. Elderly people and patients with diabetes and hypertension are mostly affected. Cases of kidney disease are disproportionately increasing in developing countries such as India, where the number of elderly people are increasing. Also, treatment costs of dialysis and kidney transplantation creates a huge financial burden for the majority of the people and to the community. Protein energy wasting associated with the kidney disease is an independent risk factor for increasing morbidity and mortality. Also, there are many other metabolic alterations which are affecting the patients. So, chronic kidney disease is a worldwide health crisis. It can be treated with early diagnosis and treatment, and it is possible to slow and stop the progression of the kidney disease. So, today is the World Kidney Day, which is honored worldwide on annual basis on the second Thursday of March, started in year 2006, was initiated by the Joint Committee of International Society of Nephrology and International Federation of Kidney Foundation. It is a global health campaign celebrated every year all across the world, focusing the health and importance of major body organ, that is kidney, with aim of reducing the occurrence of kidney diseases as well as the related health problems. So, World Kidney Day 2019 has a theme of kidney health for everyone, everywhere. So, to understand and address the metabolic and nutritional challenges of acute kidney injury and chronic kidney disease patients, we have two experts joining us today, Professor Mirai Karavatian from UAE and Dr. Arun B. Shah, nephrologist from Lilati Hospital, Mumbai. So, to begin with the first expert, Dr. Mirai B. Karavatian, who is into clinical dietetics, academia, professional dietetic trainings, clinical research, health policies, and statistical analysis. Currently, she is associate professor in nutrition and dietetics in the Department of Natural Sciences and Public Health, Jahid University, UAE. She has done her PhD in health promotion in medical sciences, Maastricht University, Netherlands. Also, she has done the Masters of Science in Nutrition, American University of Beirut, Lebanon, and BSc in Nutrition and Dietetics, American University of Beirut, Lebanon. She is an internationally experienced academic with a strong background in clinical nutrition and research demonstrated by 15 years of her experience. Okay. So now I hand over it to the Professor Mirai. Professor Mirai, over to you.
Good morning. It is an honor and pleasure for me to actually join dietitians and healthcare professionals in India one more time. I will now share the slides. So, good morning again. Today we will be talking about renal nutrition, its assessment, its management, and its effect on malnutrition. First of all, in medicine, they say first do no harm. So one of the first thing is correct diagnosis. That is why here you have, if you see the slide, early detection of any potential renal failure. Any obese, any diabetic patient needs to be screened for albumin in the urine, which is detected with the urine dipstick. Once that is done, you can identify if the patient has micro or macroalbuminuria. You can see the numbers on the screen. Once it is microalbuminuria, it can easily be reversed. So you can actually change the destiny of a patient, from a patient who is potentially going to kidney disease to a patient who will prevent it and never have kidney damage. Microalbuminuria, which is stage 1 of diabetic nephropathy, which you would have it either if the patient has diabetes, uncontrolled diabetes, but it also happens among hypertensive or uncontrolled hypertension or uncontrolled obese patients. What happens is this stage, as I said, is reversible. Macroalbuminuria is not reversible. It almost coincides with the stage 1 of chronic kidney failure. And the problem with chronic kidney failure is that once it starts, it does not stop. The only thing we can do is delay the progression to end stage, but we cannot stop it. So again, it is a very cost-effective screening tool. Albumin in the urine, done through a urine dipstick. We can educate the patient and they can check on themselves every 6 months. If there's any alarming data, they can come to their healthcare professionals and say, something's happening wrong. How to identify which stage of kidney failure it is. If you don't have the medical diagnosis, you can find out what you need. Of course, if you have medical doctors around you, then they can do the formula and do echography, echo for the kidney, see if the kidney is shrinking and accordingly decide. But if not, if you have a kidney failure patient in front of you and you do not have access to medical doctors, but you need to understand what to give them, first of all, you need to understand if they have chronic kidney failure, which stage it is. Now, the stage of kidney failure is detected through this. One of the formulas is Cockcroft formula. And as you can see on the slide, it is, you have to put age, weight, plasma, actual plasma creatinine, and then you can have the number. You will be calculating glomerular filtration rate, GFR, which is the ability of the kidney to filter all the excess nutrients from the blood. If it is a male, you keep it as is. If it is a female, you multiply this by 0.8. The GFR, the glomerular filtration rate, has to be more than 90 to be considered a good and strong and normal glomerular filtration rate. If it is less than 90, then we start kidney failure. And if it is less than 15, if you see on the slide on the red part, then that means that's end stage. Now, before we go on, we need to understand which weight we need to use to estimate the nutrient needs. To identify the weight, we need to have a few parameters before. One of them is frame size. To have the frame size, you need to have wrist circumference and height. You can see this. Later on, you can zoom in into the details, but if you have the height and the wrist frame size, and I'm going to remove my watch so that I actually show you. It's very important to actually pass it through the bone, the measuring tape, and then the height divided by waist circumference, you will get the frame size. Once you get the frame size, that's one of the parameters you need to identify the weight that you will be using for nutrient calculation. Stay with me. The next is, if you don't have a height, you can actually get the height from elbow length. As you see here, basically, this is the elbow length, and it is very important to go from this bone to this bone. And you see the elbow, the length is highlighted in red. And you've got for males and females. For example, I've given you an example in the circle. If you've got the elbow length of someone who is a female, less than 65 years old, and her elbow length is 24, then her height becomes 162. So this makes it easier for people that are kind of bedridden, don't have a scale next to them, not to get out and move, and you can have access to the elbow at any time. Next, which is the most important part, is standard body weight. Standard body weight is the correct way to be used for nutrient calculation, not just for renal failure patients, but for most chronically ill patients. Standard body weight takes into consideration that the normal BMI of a patient who is chronically ill and who has inflammation should not be 20-25, should be 22-27. So it's a little bit higher BMI, the normal BMI for chronically ill patients. Why? Because these patients are at a very high risk of malnutrition. You want to prevent malnutrition. How do you prevent malnutrition? You make your cutoff points a little bit higher so that you have a safety cushion to fall on. So the normal BMI would be somewhere between 22 to 27 for anyone who's chronically ill and has a catabolic disease. It could be renal, it could be liver, it could be cancer. A lot of chronically ill diseases that are also catabolic. So we're going to go into standard body weight. standard body weight is an equivalent to the ideal body weight, but coinciding for a BMI that is a little bit higher than what we usually know, that is BMI 22, 27. So if you can see on this slide, so standard body weight, to calculate it, you need gender, you need height, and you need frame size. Once you've got those, if you see the example that I've highlighted for you, this is a case where you have a patient who is less than 54 years old, 165 centimeter, and if she's medium frame size, then her standard body weight is 63. So this will be the ideal body weight, the replacement of ideal body weight that you will use for this chronically ill patient. Do not use ideal body weight for chronically ill patients. You would be underestimating their needs. Now, you would use the standard body weight for nutrient calculation, or if the patient is overweight or obese, then you have to use adjusted standard body weight. Adjusted standard body weight will come in a little bit in a minute, and I will explain. But just do remember that if the person has a BMI between 22 to 27, then the standard body weight as is will be used for all nutrient calculations. If the person's BMI is above 27 or below 22, so you consider the person either overweight or underweight, then you have to do something called adjusted standard body weight. We'll see how to do that in a minute. So this is adjusted standard body weight. If you see, there is, I'm going to try to, I don't have access to my pointer. Here. If you see here, you've got edema-free body weight, which is easy to get for dialysis patients. Post-dialysis, you get their dry body weight, plus the standard body weight minus the edema-free body weight. Every time I say edema-free body weight, it's actually the actual body weight. So the current actual body weight, but edema-free. Post-dialysis, it would be post-dialysis weight. And if a patient is not on dialysis, in a bit, I will tell you how to calculate that. So you see edema-free body weight, standard body weight, and then times 0.25, you would get the adjusted standard body weight. The adjusted standard body weight is what you will use to calculate energy, to calculate protein, to calculate potassium, to calculate phosphorus. So for all your nutrient calculations, you will use either standard body weight for a normal BMI person, or you will use adjusted standard body weight for anyone who's overweight or underweight. This formula, to whoever I've taught before, would know that I'm in love with this formula. Why I'm in love with this formula? Because post-dialysis, it's easy to identify dry weight. Pre-dialysis, so someone who is not on dialysis, it's difficult to identify dry weight, right? So who would you have a problem that you would like to identify their dry weight? Renal failure patients that are not on dialysis, right? Liver failure patients who have edema and ascites, congestive heart failure patients who also have water accumulation in their lungs or in their body. So all of these patients are people that you put them on a scale, you find out what's their weight, but you don't know how much of that weight is just water accumulated, right? And if you want to identify what's their current weight, then it's difficult to identify, right? So this formula helps you out. This formula tells you. Now let's go into, and I would recommend, if you do have a pen and paper, to actually try to play around with this formula right now. So we've got step one, normal total body water. We have to calculate the normal total body water. What you do is you take the actual body weight. So let's assume you have a patient who's 60 kilos, okay? Just put 60 there. And we have to multiply it by the percent body water. The percent body water for males is 60% and for females is 50%. So in this case, the patient would be actual body weight, which is, as I said, 60, multiplied by 50%. So we've got step A, 30, right? Are you following me? Step B, we have to calculate. So far we had normal total body water. So what is expected from a person, female or male, with a certain body weight to have body water. That's the normal. But now we have to calculate the actual. You need serum sodium for that. Now, the good thing is that anyone who is hospitalized has a serum sodium. So actual total body water, you will have 142 mg per liter, which is the normal sodium levels in a body, times the liters of normal total body water, the one that we got from step A, which was 30, if you remember, divided by actual serum sodium. For the fun of it, for the sake of the exercise, imagine that the actual serum sodium of this patient is 120. So step B would be 142 times 30 divided by 120. Could you do that? I'm actually right now going to do that, and I want you to also do that yourself. 142 times 30 divided by the actual serum sodium, 120. I got 35.5. Did you get that? I hope you did. So step B is 35.5. You remember how much was step A? 30. Step B, 35.5. There's a 5.5 difference. We come to step C and we say excess body water is actual total body water, which was from step B, 35.5, minus normal total body water, which was from step A, 30. So you find out that you've got 5.5 kilo excess body water. So if this person was 60 kilos, that's what we started with, right? We assumed, we put it on a scale and we found out that she was 60 kilos. If we had used that 60 kilos for any calculation as an actual body weight, we would have done a big mistake. You go to step D and you find out that dry weight is actual body weight, 60, minus the excess body weight from step C, which is 5.5. So you would have 54.5 kilo as the dry body weight. And you would use that to do BMI, to calculate BMI, to calculate your adjusted standard body weight, if you need. Is this clear? I hope this was easy, because very often when I do a workshop and I explain this to dietitians, if they don't practice on the spot, they would nod, but later on never apply. I would hope that you would apply. And this is not specific for renal failure, note. It would be for anyone that you have that has excess body water and you want to know their dry weight and you don't know how much is the dry weight. How many times you've had that you go to the medical team and say, how much is the edema? And they say LL2, 2 levels, 3 levels. And you're like, okay, but how many kilos is that? Yeah. So now you've got a tool in your hand. Interdialytic weight gain, something that is very close to my heart because it is not very well calculated among most dialysis units. When a patient comes on Monday for a dialysis and comes on Wednesday for a dialysis, the interdialytic weight gain between the two should not surpass 4% of his dry weight. What did I just mean? Let's say on Monday, post-dialysis, they left the hospital or the dialysis unit with 60 kilos. And on Wednesday, they came 63. Those 3 kilos are not fat accumulated, they're water accumulated. So that water accumulation is the interdialytic weight gain. Now that 3 kilos has to not be more than the 4% of their dry weight. Do note that in dialysis, it's very easy to find out the dry weight without the previous calculation that I taught you. Post-dialysis, you put the person on a scale, you find out what's their weight, that's the dry weight. So let's say Monday, the person left with a 60 kilos, that was the dry weight. Wednesday, they came back with 63. So 3 kilos interdialytic weight gain. You want to make sure you calculate to see how much a percent 3 kilos is of 60 kilos. Once you do that, if it is more than 4%, then you go and tell the patient you've gained too much weight. My recommendation is just check what is 4% for each of your patient's dry weight and go and tell them you're allowed 2 kilos interdialytic weight gain. You're allowed 3 kilos. Don't tell them percent. It's difficult for them to understand. If they surpass this weight gain, if they gain more, then what happens is either they have to do an ultrafiltration and this patient has to go to longer dialysis, which is very annoying for everyone involved, or has to go back home with some excess water and excess toxins. So they didn't really benefit from their dialysis. Malnutrition. You would be surprised on the rates of malnutrition among these patients. Malnutrition is extremely high. Around 40% of patients in the best centers in the world in dialysis are malnourished. So you can understand that if the center is not so well equipped with the staff, the supplements, then this rate would go higher. And what's the logic behind it? Do I remember that when we talk about renal failure or dialysis, in both of these cases, we have serious protein restriction. Pre-dialysis, we tell these patients low protein diet. Post-dialysis, you think we're giving them high protein, right? But we're not, because we give them 1.2 gram per kilo protein, right? Well, 0.4 gram per kilo out of that 1.2 is actually being lost in dialysis. So what do we end up giving? We end up giving the 0.8. So nothing changed. Pre-dialysis, we were telling them, you know what? Before getting to dialysis, somewhere between 0.75, 0.8 gram per kilo. And then in dialysis, even though we claim 1.2, but actually from that 1.2 gram per kilo, 0.4 goes out to dialysis, lost in the dialysis. So we're left with the same number. So we've got these patients that we restrict protein in one way or another, but they are in a highly inflammatory and high catabolic state. So it is very easy for these patients to be malnourished. What's the problem of malnourishment? When a patient is malnourished, inflammation shoots sky high. When inflammation goes high, first it makes malnutrition worse because inflammation makes your appetite go down, makes you lose your appetite. You look into food you don't feel like eating, and increases catabolism in your body. So that's not okay. So malnutrition makes inflammation worse, and inflammation makes malnutrition worse. And then inflammation makes the kidney disease worse. You see, a long time ago, I don't know about you, but when I was a BS student, the guidelines for nutrition pre-dialysis were extremely low protein. It was like 0.4. Who remembers those 0.3, 0.5, 0.4 gram per kilo protein guidelines? Why did those get eradicated? And I'm very happy about it. Because scientists and healthcare professionals and physicians and nutritionists saw that by giving such a low protein diet, you are sparing the kidney, but you are increasing malnutrition to such a worse level that anyways, the kidney failure is progressing faster because of malnutrition, inflammation. I hope the picture is clear. So these are some reasons why would a dialysis patient be more at risk of malnutrition. But I think if you just remember what I told you, is good enough. So among dialysis and among renal failure patients, there is something called malnutrition inflammation complex syndrome, which is, or maybe in other words, if you can see it down, it's called reverse epidemiology. Reverse epidemiology is that if you have a patient who is not renal failure, you tell them have low cholesterol, have low creatinine, have decreased BMI. But when these patients are renal failure, highly catabolic, highly inflammatory, we tell them, you know what, if you have high cholesterol, if you have high creatinine, if you have high BMI, you're better than the one who doesn't. Why? Because if someone has high cholesterol, high creatinine, means they're eating protein and they're eating fat. If they have high BMI and they're eating better, means that they are at less risk of malnutrition. Do understand that once the patient is malnourished and has already a disease that increases catabolism, then this disease progresses very fast. So within a hospitalized setting, I always tell every dietitian that I see that in the hospital, first you need to treat malnutrition and then anything else. Because once the patient is in the hospital, if they are malnourished, then they will not respond to the medical therapy given. But if they are well nourished, they will respond quickly, get out of the hospital. And then if you want to do some self-management, lifestyle improvement, do that in the outpatient clinic. But in the hospital, the primary goal, in September 2018, there was a consensus worldwide. I don't know if you heard about it from the European and the American Society of Nutrition and Metabolism, ESPEN and ASPEN. And they both agreed on one thing, which is screening and muscle mass of screening, malnutrition screening, and muscle mass of hospitalized patients is of high priority, and it needs to be screened for every patient within hospitalized setting. Within the first 24 hours, you need to check their malnutrition screening using muscle mass as one of the indicators to make sure that you give early aggressive nutrition therapy. Because everybody has come to a consensus that once you prevent malnutrition, once you treat malnutrition in a hospital setting, the patients get out of there faster, and everybody wants that. Effect of malnutrition. What does malnutrition do to the patient? It increases the risk of sepsis, pressure ulcers, multi-organ failure, increased length of hospital stay, poor quality of life, increased morbidity and mortality, healthcare cost, and incidence of death. So malnutrition kills. Malnutrition is not a joke. Malnutrition is not something to be, yeah, well, it's there, but no worries. Malnutrition kills. So we need to treat it. And as a nutrition professional, that is your strength, to target and treat malnutrition. One of the things that I would like to focus on is the effect of malnutrition and no food by gut on gut bacteria. I don't know if you've noticed that recently there's a whole target of importance of the bacteria in your intestine and their effect on your health. We call these gut bacteria. So gut bacteria have been found out that they are extremely important for your health. So you want to keep them well, you want to keep them in the intestine, and when you want to keep them healthy. Two things. First, you want to keep them in the intestine, and you want to keep them healthy. How do you do that? If you do not eat, if the patient does not eat using the GI, so I'm not saying meeting nutritional needs, because you can do that through parenteral, right? I'm saying if the patient do not use their GI, even if it is just minimal feeding, but at least some nutrient is passing through the GI, then those gut bacteria actually stay within the intestine. But if you don't have any gut bacteria in the intestine, any food, in the intestine, then these gut bacteria migrate to the blood. Now, within the intestine, they were good, but in the blood, they cause sepsis because their place was not in the blood. Their place was in the intestine. That's why we call it leaky gut. Leaky gut meaning the gut is leaking bacteria from the membrane into the blood. The permeability of the membrane of the intestine increases, becomes not so smart. And when you do not have food entering the GI on a daily basis, even if it is minimal nutrition, yeah? And I don't know if you've heard about minimal enteral nutrition. So I don't need to meet the nutritional needs of the patient. At least give some nutrition, minimal enteral nutrition through the GI. Obviously, the optimal way would be to actually give all the nutritional needs through the GI. Okay? So once you give at least some nutritional needs through the GI, what happens is gut bacteria stay within the intestine. They do not migrate. You do not have a leaky gut. They stay in. Once they stay in, they continue doing their job well, and your immunity actually stays well. So, translocation of enteric bacteria is prevented by any supplemental enteral, minimal enteral nutrition feeding. The sites of enteral feeding, we've got a few sites. We've got nasogastric, the blue one. We've got nasoduodenal, we've got nasojejunal, and then for long-term treatments, we've got gastrointestinal and jejunostomy. Nasogastric means from nose to stomach, nasoduodenal nose to duodenum, nasojejunal nose to jejunum, and that you use if you want to prevent pancreas stimulation. And gastrostomy for long-term gastric feeding, and jejunostomy for long-term jejunal feeding. So these are all the ways that you can actually give enteral feeding. The scope of today's webinar is not enteral, so I'm not going to focus so much more on this. But I just want to tell you something, that the best way to eat is food per os. That doesn't work, enteral. Per os, food. Food doesn't work, nutritional supplements. Nutritional supplements don't work, enteral. Enteral doesn't work. You go to parenteral, but try to keep minimal enteral nutrition. And this minimal enteral nutrition, I must just highlight that depending on the patient's case, either you can keep it through nutritional supplements or through enteral feeding. Yeah? I mean, if you have a patient who has no problem in swallowing, but they're not digesting well, okay? They have digestion issues maybe. And you want to go to parenteral nutrition. If they can swallow, to give them nutritional supplement, just let them drink. If they cannot swallow, if they're not awake, then you give them enteral feeding. Even if it is minimal enteral feeding. So ways to prevent gut or to understand how enteral is superior over anything else. When I say enteral, meaning using the GI, doesn't really matter for me if it is food, nutritional supplement, or enteral feeding, as long as the GI is being used. You maintain the integrity of the gut, the bacteria stay within the intestine and in a healthy way. You prevent translocation of bacteria and potential sepsis. It is for sure not invasive, less risky, and does not need surgery. This is the microvilli within your intestine that if you do not use enteral feeding, then what happens is these microvilli shrink, smaller in size, and they disturb your potential digestion. So if you have a patient who's been on no GI feeding, either NPO or parenteral feeding for long term, then there has been no nutritional feeding passing through the GI. And that is why I keep on focusing on the minimal enteral feeding. These microvilli shrink. Now we're done with this parenteral or the NPO phase and we want to feed the patient. What happens? We feed the patient and they do not digest. They do not absorb. They do not absorb, not digest, absorb, because this is the absorption part. And the patient gets to have diarrhea. Nutritional supplements, mainly used for enteral, are in two forms. We've got sterile and non-sterile. Obviously, the sterile is highly recommended. Sterile is a pre-filled liquid formula that you just open with minimum handling and you just use directly to the patient. Non-sterile could be two things. One is powder form that you have to dilute with water, or kitchen-made. We've got another form within these two. We've got complete and modular. Complete is you've got all the macronutrients. Modular is you've got one macronutrient. For example, just carb, just fat, just protein. And then the last, you've got liquid and protein, powder. Liquid, obviously, is the only sterile one, and all the rest are non-sterile. Even if you have got a powder and you're diluting with water, still, it is not anymore sterile. But you do the best. I mean, for me, nutritional composition-wise, I would look into, if I'm going to look into like hierarchy, I would go with sterile, the liquid form, and then the powder form that you have to dilute with water, and then the kitchen-made. Indicators of protein energy wasting for hemodialysis. These are good indicators that would evaluate your patient. One of the easiest things I see is if you go down to the muscle mass, muscle wasting, or even if you don't have access to muscle mass indicators, just ask the patient, have you had involuntary weight loss in the past 3 months or 6 months? If it is 5% or 6 or 10%, then it is significant amount of weight loss. 5% in 3 months, 10% in 6 months. There is also another one that you can do, which is unintentional low protein or low calorie intake. So within your 24-hour recalls, you can check how much protein is the patient eating. If they are eating, please look at the formula, 0.8 gram per kilo of standard body weight per day, or obviously adjusted standard, right? And we go to the calories, unintentional low-calorie intake of less than 25 kilocalorie per standard or adjusted standard body weight for the past 2 months, then that means this patient has severe wasting. So these are good, alarming data, and I think quite cost-effective and easy to do to find out if your patient is malnourished. Renal failure. How do you identify renal failure? You identify renal failure with generalized malaise, generalized sickness, but one of the key ones are itching, which you see at the end. In the middle, you've got the metallic taste and nausea and vomiting. So these are the main symptoms. Sorry for a cramped slide, but I just want to tell you that the general diet guidelines for renal failure patients is exactly similar to a cardiovascular disease patient. So you've got 7% saturated, 10% polyunsaturated, 20% MUFA, monounsaturated, reduced cholesterol, reduced sodium. So it's very similar to a cardiovascular risk patient because renal failure increases the risk of cardiovascular disease among patients. So we deal with them as if they are cardiovascular patients. The only difference, and fiber, please look at the fiber and the stanols here. And exercise. The only difference from a cardiovascular patient to a renal failure patient would be that you just have to reduce or restrict protein and phosphorus and potassium. That's it. Or else the rest stays the same. So in chronic kidney failure, these are the things you have to focus on, but I would like to read the one in the green box. Prevent deficiencies, control edema, prevent renal osteodystrophy, but the most important for me is provide an attractive and palatable diet. Attractive and palatable diet. Why? Because if I give any one of you a diet that tells you, you know what, it will add 20 years in your life, but it's a horrible diet. It's a diet that is not attractive. It's a diet that you don't feel like eating it. Would you take it? Question yourself, each one of you, so that we understand how patients deal with our advice. If I promise you that this diet is this magic diet that gives you 20 years extra in your life, but it's a horrible diet and you have to eat it for all your life, what would you choose? I think most of us would choose having a normal quality of life rather than a low quality of life with a longer lifestyle, right? The same thing goes for our patients. For our patients, we have to give them a palatable diet, a diet that they're happy to eat. But it also allows them to restrict micronutrients and protein. That is why I highly advise every healthcare professional to couple their work with nutritionists, with chefs, with dietitians, and make sure that you create adjusted but culturally fit recipes that your patients are happy to eat, but they are adjusted in their nutrient content in a way with mild restrictions that maintains the taste, but also restricts the nutrients. And that way you get to have compliance with the diet. The protein in general, if you forget everything that I said and you remember this, I'm happy with it. Anyone who is pre-dialysis, pre-end stage 3 and 4, you give them around 0.75 gram per kilo of standard or adjusted standard body weight. And if they are on dialysis, you give them 1.2 gram per kilo. This 1.2 can go up to 1.5 to the maximum for dialysis patients, hemodialysis, and for peritoneal, it can go up to 2. Okay, so again, hemodialysis patients, if they're well nourished, you can start with 1.2 gram per kilo standard body weight and go up to 2. And if they are peritoneal, then you can start from 1.5 till 2. And if they are not on dialysis, you start with 0.75 and you can go up to 1.2 that's the maximum, that's your ceiling. Energy. Energy is standard or adjusted standard body weight multiplied by 30 to 35 kilocalories. Don't use Mifflin, don't use Harris and Benedict. If you have obviously access to indirect calorimeter, for sure use it. But if not, use this. Don't go for other energy estimation formulas. Why? Because they are hypercatabolic patients, and this is the way out for them. Protein to phosphorus management. We tell them eat high protein dialysis patients, but then we tell them, you know what, you have to restrict phosphorus, which becomes like a maze, because an impossible maze, because protein is rich in phosphorus. So what to do? We have to give them a proper diet. We'll focus a little bit more on that. Give them phosphate binders, phosphate chelators, pills that they take with the meal to chelate the phosphorus in the stomach and not allow it to be absorbed into the blood from the intestine. Dialysis, an active form of vitamin D. Now I'm going to focus a little bit more on the diet. The diet, we need to give them foods that are high in protein and low in phosphorus. So there is a new concept called phosphorus to protein ratio. And each food should have a phosphorus to protein ratio of 10 till 12, meaning every 10 to 12 milligrams of phosphorus, you've got 1 gram of protein. Look at protein as the benefit you're giving and look at phosphorus as the harm that you're giving to the patient. So basically, high biological value protein foods, meaning animal source foods, have high protein, low phosphorus. And vegetarian sources of protein have the opposite. I always want to use this bracket and talk about branched-chain amino acids. Branched-chain amino acids, leucine, isoleucine, valine, are fantastic amino acids in kidney failure and liver failure. They do not come with phosphorus. They do not increase nitrogen and urea in the blood, and they do not need to be processed through liver and kidney, but they do go into the muscle and maintain muscle mass. So in any patient that I need to reduce protein, either because of phosphorus or because of protein, and again, this would go very easily, not just for kidney, but also for liver failure patients, I would target branched-chain amino acids. Giving branched-chain amino acids, what it will do is, as I said, it will not do the harm, but it will give the benefit of a protein. In regular food, we've got branched-chain amino acids quite rich in dairy, but the problem with dairy is that they come with high phosphorus and protein. So you got to look into your dairy. For example, if you've got some cheeses or strained yogurts that are actually have been strained the water out of them, that water that has come out would have removed the potassium and phosphorus and only kept the protein, meaning the phosphorus ratio would have dropped and the protein ratio would have gone up. I hope that was clear. So I will look at this graph and look at it as the graph that tells you at each stage how to go around. This graph tells you the phosphorus, the potassium, the calcium, everything what you need to do per stage of kidney failure. For time purposes, I'm going to a little bit go faster on this. Phosphorus during the day is allowed 800 to 1000 milligram, and each food item you select has to have a phosphorus to protein ratio of 8 to 12. And this is a list, and there are longer lists online that you can actually see the phosphorus to protein ratios of different foods. Phosphate binders, just remember one thing, that they need to be taken with food. Hyperkalemia, do remember that hyperkalemia kills. It is a fast indicator. If a person eats today high potassium, today they have high potassium in their blood, and today they will go to dialysis, emergency dialysis. So what to do? We need to restrict. You need to understand properly the diet, how important it is. And this is, I can later on maybe make available through some kind of a portal, Fresenius will help me on that, an Excel sheet that can help you quantify quickly the exchanges of potassium and phosphorus, because obviously they take time. Dietary management of potassium, it is around 2 to 3 grams a day potassium, but also you have 40 to 60 milligram per kilo of adjusted body weight, okay? Adjusted standard body weight, obviously. You can go to 2 to 3 grams, or you can go 40 to 60 milligram per kilo of adjusted standard body weight. A good way to do that is, first of all, you calculate how much your diet without fruits and vegetables gives you potassium. You add them on each other. And then, let's say from this, meat starches gave you 750 milligrams of potassium. But the total, let's see upstairs, up on the slide, just a hypothetical number. Let's say the need is 1,200. So what you do is you remove 750 from the 1,200, you left with 450, and then you divide that 450 between fruits and vegetables. And that's how you decide how many fruits and how many vegetables you want to give and what type. And why did I do this fruits and vegetables? Because with fruits and vegetables, you have a choice to give a low potassium fruit, high potassium fruit, medium potassium fruit. You had them in the list before. Salt, the same thing you do. You go and plan your whole diet, see how much the diet actually gives you sodium, deduct that number from the total needs being 2,400 milligrams, and then you get a number. That number, multiply it by 2.5. That number, please see here, to convert sodium in grams, multiply it by 2.5, and then you'll get amount of salt. So for example, if you had a patient whose needs was 2,400, and you saw that through the diet, you already consumed 2,000. So you've got only 400 milligrams of sodium left. You divide it by 1,000, you get a 0.4. That's the amount of sodium allowed still on top of the existing diet, the non-seen sources of sodium. That's 0.4. You multiply by 2.5, you get a number, and that number is the amount allowed of sodium to ask the patient to add on their food. Hemodialysis. We talked about protein. Same solution about sodium. Fluid, either a patient is on or not on dialysis, the same recommendation is a fluid. You ask their urinary output for 24 hours. That urinary output, you add on it 500 ml. Let's say the urinary output of patient is 700. You add on it 500, it becomes 700 plus 500, 1,200, and you tell them this is the amount of water allowed to you. Fluid, not water, a fluid. It can be any source. Do note that you as a dietitian, you can know that your allocation of fluid is actually urinary output plus 1,000, but you don't tell that to the patient. You tell them urinary output plus 500 because you want to keep some extra allowance for all the food water that patients do not see. Vitamins and minerals, please do not forget about vitamins and minerals, especially for dialysis patients. The problem with dialysis patients is that they lose all water-soluble vitamins through dialysis. Exercise. Do not treat these patients as the victims of the world. If they exercise, they maintain their quality of life, they benefit from the dialysis, they get to have a stronger cardiovascular system, and they live longer. Empower your patients to see exercise as something that they can be doing. Studies have shown that exercise during dialysis makes these patients live longer, happier, better quality of life. This is like a summary of all the things that you need to do per every stage of renal failure, from protein, energy, electrolytes, and the rest. So I would say that just look into this page and follow it as much as you can. This is like a summary of everything we talked about. And at the end, yesterday was a registered dietitian's day, World Registered Dietitian Day, and today is World Kidney Day. I just want to remind every single one of you that nutritionists matter. And look at this guideline. This guideline says that if a patient is seen, if a dialysis patient is seen by a dietitian 2 hours a month for 1 year, they would live longer. How I've done that is because you know very well the attention span of the patient is not so long. What I've done is I've created a protocol that says 15 minutes twice a week. So it would be half an hour per week. And then by the end of the month, if you do that every time, you've got your 2 hours. If you spend 2 hours a month with your patients become excellent in self-management and they live longer. Every nutritionist has a power in their hand, which is to prevent all the nutritional problems, because at this time and age, we should make sure that our patients eat right. And thank you.
Thank you, Professor Mire, for an illustrious talk. Now we have Dr. Arun Shah with us. Dr. Arun Shah is a consultant nephrologist at Lilavati Hospital, Bharatiya Arogya Nidhi Hospital, and Hinduja Healthcare, Mumbai. He has 7 publications nationally and internationally. He was awarded by IMA 2013 on Doctor's Day as a best clinician and academician in nephrology. He is currently Vice President of Mumbai Kidney Foundation and Treasurer of Correct Trust and Amar Gandhi Foundation. Over to you, Dr. Shah.
Thank you. It was wonderful to hear a talk by a dietitian prior to a nephrologist talk. So my job becomes much easier, and I don't have to go into details of potassium and sodium of each nutritional products. I will now talk to you about how we advise diet and how the dietitian follows it up with our patients. Now, let us go to the next slide. I think I will monitor it.
Minimize this.
Where I can monitor from here? Yeah. So let us begin. Now, when we finish this talk, this module will help you to define and understand the concept of protein energy wasting. It will help you to review nutritional requirements for non-dialysis patients with chronic kidney disease, identify the potential risk of protein-restricted diets in the nutrition management of non-dialysis CKD patients, nutritional requirements of CKD stage 5 on dialysis patients, and renal-specific nutritional support. Now, what is protein energy wasting? This is always a dilemma with the patient, the relatives, and the nutritionist. The International Society of Renal Nutrition and Metabolism expert panel defined the term protein energy wasting as a state of decreased body stores of protein and energy fuels, that is body proteins and fat masses. Now here somebody might ask why carbohydrates are not included, because when you take excess carbohydrates, they are always converted into fat. So what you can see in the body is either fat or proteins. Protein energy wasting or uremic malnutrition is a distinct condition in CKD, and it is one of the strongest risk factors for morbidity, mortality, and impaired quality of life in patients with CKD. Protein energy wasting is often associated with diminished renal functional capacity. Now, what is the prevalence of protein energy wasting in pre-dialysis CKD patients? It has been studied world over, and they have shown that protein energy wasting is prevalent in 12 to 18% of patients with stages 3 and 4 on CKD. But CKD stage 5, not on dialysis, we have seen in India that there are studies coming from Chennai and Mumbai that almost 50% of patients on stage 3 and 4 and stage 5 not on dialysis, they are malnourished and they have protein energy wasting. Now, what are the etiology of protein energy wasting in pre-dialysis CKD patients? Now, all of you know that whenever a patient has chronic CKD, there is a decreased nutritional intake because of anorexia, there is inflammation, there is loss of uremic toxins, there are comorbid conditions, there is dialysis-associated catabolism, there is infection, cardiovascular disease, frailty, and many metabolic derangements. They all contribute to protein energy wasting. Now, looking at this chart, this again repeats the etiology of protein energy wasting, but it also tells you what happens when there is protein energy wasting. Because of malnutrition, uremic toxins, inflammation, and hypercatabolism, there is a decrease in albumin, transthyretin, and lipids. There is increase in CRP. The decrease in weight, decrease in BMI of the patient, decreased fat stores, and there is sarcopenia. There is increased mortality of these patients, increased hospitalizations, and poor quality of life. And there is atherosclerotic cardiovascular diseases and more vascular calcification. But against all this, there is a survival paradox that those patients who are obese, they may develop CKD in future. But once they are on dialysis, those patients who are obese, they live longer on dialysis. And that is the reason the role of nutrition comes in CKD patients on dialysis. Now, what are the methods of evaluating protein energy wasting in pre-dialysis or dialysis CKD patients? You have to look at 4 factors: the nutritional intake of the patient, laboratory measurements, body mass and composition, and there are indexes which are subjective global assessment and malnutrition inflammation score. So when we go in details of the score pattern, it is simplified into things which you can handle in your department, which you can give a pro forma to the patient or the relative to fill in and follow it up every month. This helps you to look at the progress of the patient, whether it is pre-dialysis or dialysis. And depending upon their food diaries, their weight, their muscle mass, and their biochemistry, you can determine whether patient has protein energy wasting or not. So simplifying, International Society of Renal Nutrition and Metabolism says that if you do serum chemistry, and if albumin is less than 3.8 and cholesterol is less than 100, then patient is malnourished. Then if there is a reduced muscle mass of 5% over 3 months or more than 10% over 6 months, or there is reduction in mid-arm muscle circumference by more than 10%, then there is protein energy wasting. Any patient whose BMI is less than 23 or he has unintentional weight loss over time, 5% over 3 months or 10% over 6 months, or if he loses more than 10% of body fat, then is called protein energy wasting. And when you take dietary history, if there is unintentional low dietary protein intake of less than 0.8 grams per kg per day for at least 2 months for dialysis and less than 0.6 gram per kg per day for patients not on dialysis, then it is called as protein energy wasting. And unintentional low dietary energy intake of less than 25 kilocalories per kg per day for more than 3 months, for more than 2 months is called as protein energy wasting. So the International Society says that out of these 4 groups, if you have one group present and the score is more than 3, then patient has protein energy wasting. So what are the goals of nutritional management? Our first aim is prevention and treatment of undernutrition. Second goal is correction of uremic metabolic disturbances. Third is prevention of electrolyte disturbances and hyperkalemia. Attenuation of disease progression through protein or phosphate restriction and preservation of intestinal mucosal integrity and function. The previous speaker has already told you about how to preserve the mucosal integrity and function. Now, what is the proposed algorithm for enteral nutritional support in patients with CKD? Now, you have to do periodic nutritional assessment and dietary counseling of patients with CKD. You have to take the dry weight, the laboratory measures, the appetite, the food diaries, and what are the indications for nutritional intervention. So a patient saw, though one who is not on dialysis and one who is on dialysis, if they have poor appetite, they have unintentional loss of dry weight, there is sarcopenia, albumin drops, prealbumin drops, minimum inflammatory score is more than 5, or SGA is in malnourished range, dietary protein intake of less than 1 gram, or zero point 0.5 grams for patients not on dialysis. Energy intake is less than 25 kilocalories. Then these are the patients who require nutritional interventions. And these are the patients you have to start on CKD specific oral nutritional supplements of 1 to 2 servings per day. Now, dietary intake varies between the patients, whether they are on stage 5 not on dialysis or stage 5 on dialysis. So, what is the nutritional requirement? So different societies, they give almost the same dietary advice, except for little changes in their sodium and fluid intake. We'll go by KDOKI guidelines. KDOKI guidelines says that dialysis patients who are less than 60 years of age, energy requirement is 35 kilocalories per kg per day. And those who are 60 and above and obese, your dietary energy requirement should be around 30 kilocalories per kg per day. Now, why we have to give importance to this energy requirement or calories? The important thing is when patients are not on dialysis, you are going to restrict the proteins. And if you don't give enough calories or energy to these patients, then if they are active physically, they will get their energy from the proteins. And these are the patients who become sarcopenic and they lose their muscle mass. So even if they are diabetic and once they have developed CKD, you have to maintain their calories or energy requirement. Protein requirement is 1.2 grams per kg per day for patients on dialysis, out of which 50% should be high biological value. And patients who are not on dialysis, it is from 0.6 to 0.75 gram per kg per day, depending upon what the center believes in, whether they believe in very low protein intake or moderate restriction of protein intake. Sodium is restricted as per the edema and hypertension. Fluid is restricted as per the edematous status of the patient. Potassium is restricted and phosphorus is restricted. Now, when you restrict the phosphorus, and if that, with that, if you end up restriction of proteins, then in that case, it is better to give the proteins, and if phosphorus is high in the patient, give phosphorus binders. Now, is protein restriction beneficial or risky in pre-dialysis CKD patient? And what is the rationale for dietary protein restriction in CKD patient? And many studies and many statistics are available in the literature.
Hello, everyone. I hope you can hear me. I think there was a technical error from the other side, and the team will be back. Just wait 2 minutes, please, and they'll be back. Don't go away.
Yeah, sorry for the interruption. Please, Dr. Shah, please continue.
So now, after going through some theoretical aspect of protein energy wasting and what are the recommendations of energy and proteins in the patients, let us go to the clinical side of nutritional management of the patient.
Just one more.
Next slide. Yeah. Now let us discuss a case of CKD patients on dialysis. Here we have 58-year-old female diabetic hypertensive on dialysis due to diabetic nephropathy, unsuitable for transplant due to poor cardiac function. She has a peripheral vascular disease, amputation, pancreatitis with a stent, and presented with inability to eat and weight loss. It's a classical scenario which you will find in tertiary care centers on patients on dialysis and patients in ICU. Now, these are the patients who have poor nutrition and anorexia. You have to rule out sepsis, pancreatitis, acute inflammatory state, obstructive jaundice, paralytic ileus, depression, and poor vascular access causing poor dialysis. Now, the investigations, a clinician and all imaging studies to find out what are the causes of malnutrition in this patient and what do we have to do nutritionally to improve this patient. We have to take the clinical history of the patient and you have to do the screening of this patient. And how do you do screening and assessment? There are two ways. Either you do subjective global analysis or malnutrition inflammatory score. It's a simple thing. Every patient, whether an outpatient for dialysis or inpatient, you should give these two forms. One for subjective global analysis, where it is mainly the history of the patient, whether he is all right, whether there is a change in weight, how much is the dietary intake from the food diaries, any GI symptoms, functional capacity, any comorbid conditions, and routine physical examination. Or this is a more detailed form that every nutritionist or dietitian should have with them if they are looking after a dialysis center. Now, this is a part subjective global analysis plus partly biochemistry also. This again includes dry weight, dietary intake, gastrointestinal symptoms, functional comorbidities, then other comorbidities, then physical examination of fats, muscles, body mass index, then serum albumin, serum total, and binding capacity. So these are 10 parameters which are given scores of 0 to 3. And any patient who has a score of more than 5 is called as malnutritional inflammatory score, and they are not nourished properly. So you have to look after them. And if you see a serial chart, as the previous speaker said, that every month you spend about an hour or two with the patient and the relative and just chart it out. And if you just go through this chart, you'll come to know whether the patient is doing well or is unwell. Now, we have gone through this, so you have to again concentrate on serum albumin. Pre-albumin is not done in many centers in India. Cholesterol is very easy to do. Anybody who has a cholesterol of 100, don't be very happy, oh, he's doing very well, his cardiovascular system is good. a patient on dialysis when cholesterol is low is a poorly nourished patient. Look at the BMI of the patient, look at the change in weight over last 3 months, last 6 months. Then when you have seen these changes in the patient of weight and biochemistry, and you are doing periodic nutritional screening, continue to do periodic nutritional screening. And when you are doing this, you have to help the patient by nutritional counseling. You have to ask him to optimize his intake of calories and proteins, and you have to manage comorbid conditions. And again, coming back to what are the indications for nutritional intervention, where you have to advise the patient away from your regular diet, where you have to take renal-specific nutrition. The indications I already told you, this is for reinforcing your idea about the group of patients where you have to give more time. Now, when you see a patient who is not good, who has got a protein energy wasting, you have to start CKD for a nutritional supplement. If there is an improvement, you maintain the nutrition. If there is no improvement or there is a deterioration, you have to intensify the therapy and you have to give adjunct therapies. Now, when you see a serious patient, your nephrologist will correct cause of fever, vomiting, diarrhea, pancreatitis, ileus. He will dialyze him well, but your job is to improve the nutritional status of the patient. So what are the strategies? These 4 blocks are very important. You have to give diet advice with nutritional counseling all the time to all your CKD patients. With counseling, you have to give them oral nutritional supplements if they are not eating well. If orally they are not able to take, you have to go to enteral nutrition by tube feeding. And at last resort, you have to give them parenteral nutrition during dialysis. Now, which are the patients who should receive nutritional intervention? The KDOC very clearly says it's not that all patients on dialysis require nutritional supplementation, but individuals undergoing maintenance dialysis who are unable to meet their protein and energy requirements with food intake for an extended period of time should receive nutritional support. So how do you give nutritional support? So if you have to just support them initially for some small poor intake, you ask them to take nutritional support when they are taking water at home or when they are taking medicines at home. So you give them renal-specific supplement with water, either by the nursing staff or by the relative at home. And these are a valuable addition to treating and preventing protein energy wasting in CKD. Now, when we talk about renal-specific supplements, the previous speaker has already covered the importance of regular feed and renal-specific feed. Renal-specific supplements are good in proteins for dialysis patients and non-dialysis patients. You have low protein therapies available. They have low glycemic index. Their MUFA is high. The minerals are low. Fluid volume required is low. Caloric density is high and fiber is high. And we did a study in our hospital at Juhu, and we decided to give all dialysis patients for 3 months oral nutritional supplement during dialysis, those 4 hours when they were there in the department with us. So either just before starting dialysis or during dialysis or at the end of dialysis, we gave them about 90 to 100 grams of oral nutritional supplement, which was high protein. And we did it for 3 months. And we did their investigations prior to starting the study and at 1 month, 2 months, and 3 months. And what we found that all these patients, when they were given oral nutritional supplement during dialysis, their hemoglobin improved, their albumin improved, their SGA score improved, their MIS score also came down. And after this, we have continued to give all these dialysis patients nutritional supplement during dialysis when they are not eating well. But those patients who are not eating well, when they stop this nutritional support, there again hemoglobin and albumin drops. And when you are in ICU, there are some patients with AKIs. I will just brush on this topic. The requirements of protein in patients with AKI is 1.5 grams per kg per day. You have to give amino acids to these patients, and the energy is 20 to 30 kilocalories per kg per day, and non-protein calories should not be more than 25 kilocalories. Carbohydrate should be 2/3 of non-protein calories as glucose and 1/3 of non-protein calories as fat. So this is your job to exactly calculate how much carbohydrates to be given, how much fats to be given, and how much proteins to be given. And the ONS which are available, low protein and high protein, they give good calories for 100 grams. They give the pre-dialysis segment, there is a low protein, dialysis segment, there is high proteins, electrolytes are low, sodium is low, potassium is low, and phosphorus is low. These are mainly whey proteins. And since it is a vegetarian protein, it is quite accepted by the patients in our country because most of them are vegetarians. And when you give these oral nutritional supplements to these protein energy wasted patients, it has been shown that it lowers mortality, it improves quality of life, it increases body weight, it increases lean body mass, improves anti-anemia response to erythropoietin, and there is lower fluid which goes in. There is increase in albumin and pre-albumin levels, increase in energy, and subjective global analysis shows improved nutritional status. There's less constipation and better compliance. Now, there are two studies which shows that those who are given oral supplementation, their quality of life improves and their hospitalization need comes down. Now, it is not only about calorie and proteins, but it also gives you water-soluble vitamins, fat-soluble vitamins, and trace elements. And trace elements have an important role in CKD patients. And when you give this ONS, they get these trace elements like zinc and selenium. Now, when patient, you have done the counseling, you have given oral nutritional supplement, you have given intradialytic nutrition, you have given enteral tube feeding, and then you have to give parenteral tube feeding. Now, enteral tube feeding is the next step for those patients who have a functional intestinal tract but are unable to meet nutritional needs with food or ONS because of anorexia. And when you there is protein energy wasting, the tube feeding, as the previous speaker has said, you can either put a Ryle's tube, you can put either gastrojejunal tube or just an NJ tube. And it provides nutritional needs, it provides balanced nutrition, it provides total parenteral nutrition to the patient. Now, when your enteral nutrition is not feasible because of some obstruction is ileus, then you have to go on to parenteral nutrition. Now, there are some complications can occur due to tube feeding, which you have to look into. A patient is not aspirating, it doesn't have any esophagitis, there is some fluid overload. You can sometimes use prokinetic drugs to improve the reflux. When the gut is not working and you end up giving parenteral nutrition, it's very difficult. It is an expensive thing. So as far as possible, use the gut. But when you have to give parenteral, that is possible only during the dialysis. And there are some side effects or complications of parenteral nutrition like azotemia, the electrolyte imbalances, there is immune infections, there is hyperinsulinemia, there is hyperglycemia, the elevated liver function. So you have to be careful when you are advising parenteral nutrition to the patient. So taking home message, the prevalence of protein energy wasting is high in CKD, and it is particularly high in those who are on dialysis. Patients on dialysis have hypercatabolism and undernutrition. Dietary guidelines are restrictive, And what we have observed that patients get confused and they continue the pre-dialysis diet at low protein, and regular nutritional screening followed by assessment is fundamental to integrating nutritional therapy into practice, and benefits of oral nutritional supplementation in CKD are reflected in the improvement in outcome. So why we are talking about nutrition today? There are so many medicines available to treat hypertension, diabetes, dialysis, but in the treatment of CKD, what are the important milestones which have benefited patients in the last 50 years? 50 years back, there was no dialysis. It started in 1960. There was a better control of hypertension with newer drugs, control of diabetes with the insulin. So the number of patients developing CKD came down. There's improvement of dialysis therapy. There's a transplantation. Patients who used to remain anemic, they do very well with erythropoietin. But with the scope now for these patients to improve further, it is the renal nutrition. And here is the scope where the role of nutritionist or the dietitian comes into the picture to further improve quality of life of the patients on dialysis till they opt for transplant. Thank you.
Thank you, Dr. Shah. It gives a lot of insight to us in understanding the CKD, the acute kidney injury patients. So my first question is to Professor Mire. Professor Mire, are you there?
Yes.
Yeah. So while monitoring the CKD patient with malnutrition, so it is doing serum creatinine is only good or good enough, or we need to do the GFR also?
If I may understand the question correctly, you're asking for GFR or you're asking for malnutrition?
Yeah, so CKD patient with protein energy wasting, while monitoring this patient, so only we can rely on the serum creatinine, or we need to, in addition to do the GFR also?
For understanding the kidney failure stage, creatinine is not enough. We need to do GFR so that we can understand what level of kidney failure it is. You can use plasma creatinine in the formula, but creatinine alone cannot talk. It tells you that there is renal failure, but I mean, it doesn't tell you.
Adding to this, to find out protein energy wasting, creatinine has got no value. You have to do albumin or cholesterol. That is biochemistry to give us a guidelines whether patient is developing protein energy wasting or not. Pre-albumin is not available in all the laboratories. And another thing, patient on dialysis, then creatinine is an important tool. If you don't want to do any other test, if patient's creatinine is low, that means they are not eating well. Then the creatinine has a great value. Patients who are keeping creatinine of 8, 10, 12, they are doing very well because they are eating well. So these are the patients where creatinine has a value. But in a pre-dialysis segment, you cannot understand protein energy wasting unless you have either done measurements of body mass or fat, or you have taken dietary history, or you have taken albumin or cholesterol levels.
Sorry, because it was cutting at the beginning, I couldn't hear the question well. So your question is about protein energy wasting. Thank you, doctor, for the I will answer the following. The problem with albumin is that we used to see it as a nutritional indicator. Now it is rather an inflammatory indicator, because once you have inflammation and CRP elevated, albumin drops down. So you wouldn't understand if albumin has dropped because of inflammation or because of malnutrition. So albumin in such cases is very easily misunderstood. And most of the blood tests are also misleading sometimes. That's why we're going more and more to rather anthropometrics and specifically muscle mass. Muscle mass specifically could be through BIA, body compositions, where you can check the fat and muscle. Recently, what I've been using in hospital settings is a very cost-effective tool, which is hand grip. You just ask the patient to hold the hand grip, and according to the weight that they come, if they pass through the certain criteria, then that means they don't have muscle wasting. So we're going more towards more anthropometrics rather than blood tests, because we're seeing that blood tests are very well affected and they could be deceiving when there is inflammation.
I agree with you. So the functional capacity of the patient,
yes,
the diary of the patient which you have to take, dietary intake history which you have to check, and then the biochemistry makes a part, last part. What she correctly said, albumin takes about 3 weeks to fall. It doesn't fall rapidly. The one which falls rapidly is a pre-albumin. It's a costly test and not available everywhere. So you have to depend on everything. You have to depend on the quality, depend upon dietary history, depend upon the muscle mass.
So in continuing, there is a question from Bangalore. Can we give high protein diet for a non-dialysis patient with high creatine level with low albumin level?
I would say the magic amino acids, branch chain amino acids. So in that case, I would give 0.7, 0.8 gram per kilo of adjusted standard body weight. And then if you wanted to give, if you had no renal failure and you were looking into patient, you wanted to give 1.2, but you're restricted to give 0.8, let's say, give the 0.4 gram per kilo from branch chain amino acids. Right. Because when you're saying non-dialysis, but is on kidney failure, you're saying high creatinine, even if low albumin, you don't want to kill the patient with uremia. So no, you do not give high protein, you tweak the protein. You see, you give branch chain amino acids. So you give the 0.8 or 0.75 gram per kilo from regular proteins, and then you level it up with branch chain amino acids. And some of the branch chain amino acids even come with some calcium in them. So they actually work as phosphate chelators. So what I like about some of these branch chain amino acid pills, that if you give that, then you reduce phosphate chelator pills from the patient. And this helps in, not adding so much medication and pills.
Now, I have a little additional point in this. Patients who are not on dialysis and creatinine is high and albumin is low, if you improve their caloric requirement, if you bring up their calories to 30 to 35 grams per kg per day, then there's any muscle loss, muscle is not utilized for energies, then gradually the albumin comes up because you are giving good energy for day-to-day activities and they start doing well. So it is not only about protein, because you can't give large amount of proteins just to improve albumin. You have to restrict the protein to slow down the progress of the renal disease. But moment you improve the caloric requirement, they do show increase in serum albumin over a period of time. So here the main crux comes, that you maintain the caloric requirement of 30 to 35 grams kilocalories per kg per day.
So is this calorie requirement? Yes, ma'am. Please.
Sorry, as the doctor was saying, there's something called protein sparing, and with fat and carbohydrate, you spare the proteins so that they go to their job, and you use energy from fat and carbohydrate.
Right.
So that is why these patients are taking a hypercaloric diet, because we know that protein, every milligram of protein needs to be spared to go do its job, which is muscle sparing, muscle maintenance. And then we can give them enough carb and fat to make sure that no energy is used from protein. All the energy is used from there. That's why the name is energy protein wasting, not just protein wasting.
So in this patient, if there is edema and that is leading to the normal or more than normal weight is there, then is the calorie requirement would be still high, or it is we have to give normal or some hypocaloric?
Now, the patients who are edematous and that edema is not responsive to diuretics, then for 2 or 3 days or 5 days, we give them intravenous albumin with diuretics just to remove the edema. It is not given for a longer period of time. And then these patients are instructed, you restrict your salt, restrict your fluid intake. It is not only water, it is your fluid intake. It includes your tea, coffee, soup, everything. So once they restrict salt, once they restrict fluid, they take adequate diuretics, the edema will be taken care of. Only in the cases of emergency where they are resistant to diuretics, we give 3 or 5 days of IV albumin. Oral proteins doesn't help at that time because they take time to build up in the blood. So that's the answer for this edematous patient.
And how much protein you recommend during dialysis?
During dialysis, as I said, patient should take at least 1.2 to 1.3 grams per kg per body weight. Now, dialysis procedure itself is a hypercatabolic procedure. Now, suppose if you are dialyzing 3 days in a week, so day on dialysis, if you take more proteins, around 1.4 or 1.5, the next day you end up taking 1 gram protein, still patient will do very well. So the important thing is supplementation of oral nutritional therapy to a patient who is not doing well on the day of dialysis is that you are supervising that supports to the patient. That when you give about, suppose if you are giving 100 grams of high protein diet, patient will receive about 500 calories, will receive about 20 grams of protein. Our first aim is go back and eat well at home. But when they are not doing well, at that time it is a supervised therapy, and which I showed you in my study that helped the patient, because no matter what you tell them, they do not follow the advice at home.
This question which I'm going to ask, it was asked before also during your previous visit to India, Professor Mire. So in between the dialysis, during the 2 sessions of the dialysis, how much protein you recommend? You recommend same as that during dialysis, or it is the low protein diet?
You mean actually during the dialysis session?
No. Between 2 dialysis sessions.
Interdialysis.
It's a lifestyle. I mean, once they are on dialysis, they keep on eating the same thing, whether it is during the dialysis session or it is the next day. All they need to eat is the 1.2 gram per kilo of protein. It doesn't make a difference if this is today the dialysis session or tomorrow is the non-dialysis session. And I would continue on that and say protein definitely has never made an issue, but a lot of centers give high potassium, high phosphorus foods during the dialysis session. And I would like to tackle that even during the dialysis, one patient should not be eating high potassium, high phosphorus. They should be continuing eating their restricted diet. And there are 2 benefits from it. First of all, the patient, because you see, when the patient eats, it usually takes around 3 hours for the nutrients to reach the blood. And the dialysis session is around 4 hours. So usually by the time they're out of the dialysis session, these high nutrients are back in the blood. So the person left dialysis, they were supposed to be completely clean of high potassium and high phosphorus, but they're not, because they ate high potassium, high phosphorus diet during the dialysis session. So here, one added value that we need to give them the restricted food during dialysis. And another added value of that is, since you've got a bunch of nutritionists and dietitians in the hospital, they can modify the recipes, make them delicious, but low potassium, low phosphorus, give it to the patient, and it becomes an educational effort or a session for the patient to see that, oh, by the way, the restricted food is still delicious. And this would actually make them comply to the diet, because the whole concept is, as I said earlier, malnutrition, attack malnutrition, attack malnutrition. Very often these patients, they don't like the food, so they go into a self-imposed restricted diet, which means that they start, because they don't know what to eat, they start eating very little from everything, which ends up with, yes, low potassium, phosphorus in the blood, but also low protein and low energy. And this is one of the major causes. The self-imposed restricted diet is the major source of malnutrition among these patients. And this could be easily prevented by palatable diets. And these palatable diets, they're very difficult to apply at home if you don't have an example. So within the hospital, giving a restricted diet first allows the patient to go home well, One. Number two, during dialysis, they would learn, oh, by the way, it doesn't look so bad. I'll eat it. You see, and this encourages them to try the same recipe at home.
Good. So there is another question from Gurgaon. What are the nutritional recommendations for salt wasting nephropathy? Yeah.
Yeah. Okay.
So this is a challenge, and all the time these patients have to be given adequate salt and adequate water intake, because they develop interstitial nephritis, and they pass a lot of urine and they pass a lot of salt in the urine. And there's no medicine to stop that, but continuously you have to look at the bicarbonates, the fluid intake and the salt intake as the blood pressure permits. And we always look at the sodium. If the sodium is not dropping much, you need not do anything else to improve the intake. But if salt wasting nephropathy patient is coming repeatedly with hyponatremias, then you have to work with them on the diet.
Okay. Any opinion, Professor?
Yeah.
So there is another question to you, Dr. Shah. How in your practice you improve the hemoglobin level?
We always check patients who are anemic. We check their vitamin B12, iron levels. We do iron studies like ferritin and TIBC levels. We give them oral iron if they are not on dialysis. But once they are on dialysis, it's very simple. Once in a week, we give them IV iron, 100 milligram. We give them vitamins IV twice in a week. We give them La-carnate injection once in a week to improve their muscle strength. And if their hemoglobin is less than 9, we give them erythropoietin. Now, this erythropoietin, initially, years back, we used to give 3 times in a week. But now we give them once in a week, large dose, or we put them on darbepoetin or pegylated erythropoietins. Very rarely we have to give blood transfusion to the patient, but with IV iron, IV vitamins, La-carnate, with a good diet, the erythropoietin requirement also comes down and patient does well. And why we should do it during dialysis? Because this is all supervised. You know exactly what is delivered to the patient. Otherwise, at home, whether it takes properly or not, whether it maintains the cold chain for erythropoietin or not, you do not know. So we have a policy that on dialysis, we deliver all these injections when they come and visit us for dialysis.
I would also suggest making sure that patients eat well during dialysis days and non-dialysis days. And here comes the role of a nutritionist to actually make sure to assess them well, because if the patient is not meeting their needs through food, maybe nutritional supplements, very often they help a lot, because they're easy to just swallow. It has been, there are studies that they showed the effect, comparative studies, nutritional supplement, and then interdialytic parenteral nutrition. And when you compare all the fancy treatments, we come back to nutritional supplement and food. If the patient is being able to eat properly, or you're meeting their energy needs, protein energy needs from nutritional supplement, then that has been shown to be a highly cost-effective treatment to prevent a lot of these things. And the doctor talked about erythropoietin, and I would like to emphasize on that very often the nutritionist would be helping the medical team to identify resistant anemia, because resistant anemia comes often. There are many reasons for resistant anemia, but one of them is low protein pool. Low protein pool can be easily identified if the dietitian is just doing a 24-hour recall. She sees that the patient is eating very low protein, very low energy. That tells her that maybe there is a malnutrition problem. She asks the medical team, they can do a blood test. If the albumin and all the rest of the proteins are very low, then the patient, no matter how many times he or takes iron, erythropoietin, whatever, if protein pools are not enough, then nothing can be fixed. I've seen many patients that through just 24-hour recalls, how silly it is, just 24-hour recalls, we've prevented unexcessive or unneeded blood transfusions, because they've seen that, the patient's resistant anemia, he's not responding to treatment, blood transfusion, and we've been able to prevent all that extra unnecessary treatment just by 24-hour recall. So there's a lot of source in identifying what the patient is eating. And I really believe that the dietitian and the doctor have to work hand in hand, because one can help the other see the blinded sides. It's very difficult to identify everything about the patient. And the more the people collaborate together, they actually can deliver the more tailored, the most cost-effective treatments to the patient.
Yeah, I agree with you. It's the inflammation during dialysis because of malnutrition and poor protein intake, which causes resistant anemia. And as I showed you in my slide, the study which I did, when we gave that supervised therapy of high protein, high calorie supplements, their hemoglobin also improved. It's not only albumin, the hemoglobin also improved.
Yes.
And we have other slides which showed the requirement of erythropoietin did come down. So that helps in saving the finances of the patient.
So there is another question, Dr. Shah. What are your dietary preference in metabolic acidosis with insulin resistance?
See, insulin resistance, and if patient is diabetic, or then you have to treat the patient with insulin for his diabetic control. But in metabolic acidosis is mainly there's some reason. The main reason the patient developing metabolic acidosis is either sepsis or hyperkalemia. So you have to find out what is the source of sepsis. You have to do imaging studies. You have to give antibiotics, bring the CRP, PCT down, and correct the fluid level of the patient and correct the metabolic acidosis. In patients who are hyperkalemic, it is much easier. Just correct potassium level, their bicarbonates will come up, and their metabolic acidosis will be covered well. So there is no nutritional therapy as such initially. It is first thing you have to find out what is the cause of metabolic acidosis, and you have to, it's a cause-effect relationship. To treat the cause, metabolic acidosis is corrected, and whatever the damaged metabolic acidosis or the primary condition is left behind in terms of anemia or malnutrition, which you have to correct with nutrition support.
Okay, understood, sir. Professor Mere, there is a question for you. The patient after renal transplant, if there is a electrolyte derailment is there, then you prefer to give the restricted diet, or how it will be?
Can you repeat the first part? If the patient is
after renal transplantation, if they after kidney transplantation, if there is a kidney transplantation, if there is a electrolyte derangement, then you give restricted diet. How it will be?
Okay, as much as I heard, you're asking during transplantation, what is the diet?
After renal transplantation.
After transplantation, yes. After renal transplantation, what is the diet? Yes. Well, the diet is very much dictated by the treatment that is taken, specifically the immunosuppression diet treatment. But basically with the protein, there is no problem. You treat it as if any surgery, post any surgery, you give a high protein diet to allow wound healing. So 1.1, 1.2 gram per kilo protein is fantastic for these patients. You could keep on following up on the electrolytes. Once they're normal, then there is no more need for electrolyte restriction. But post-transplant, the whole challenge is first to give a neutropenic diet, which is a sterile diet, one. Second, to make sure that the treatment, which is mainly the corticosteroids that are given, that the diet matches the doses of the corticosteroids. Because if the corticosteroid is very high, like 40 milligrams per day, then the patient has to go through a low salt, low sugar, low fat, high calcium diet. See, low salt, low sugar, low fat, high calcium diet. And if it drops down to only 5, then we give low salt. So like a 5 grams low salt, 10 low salt, low sugar, and then 40 low salt, low sugar, low fat. But at all times, high calcium, because it eats the bone. So the challenge becomes completely different. It's a complete different page, which is first neutropenic, a sterile diet, and then making sure that it matches the treatment. With electrolytes, it becomes just a trial error, not trial error, but you watch into the blood test. What's happening in the blood test, you respond to it with the diet. And anyways, post-transplant for at least 2 weeks, the patient
Is it on? Yeah.
having blood tests, so you can respond to it very quickly.
Now, I will just add a little one point here. As a nephrologist, we always tell the patient, after a successful transplant, for the first 3 months, behave like a normal patient. You can eat what you want, you can drink as much as you want. Yeah. But even after 3 months of transplant, even if they have a normal renal function, we tell them, okay, you go to pre-dialysis CKD diet. Restrict your proteins to 0.8 grams, restrict your salt to 46 grams, control your potassium intake, control your calorie intakes because you are likely to develop diabetes because of steroids and tacrolimus, and fluid as required. So to be on the safer side, all these patients who are electrolyte things come up because immediately post-transplant, they start taking a lot of fruit juices, a lot of dry fruits and salads and other things. And that is where potassium can suddenly go up. And after 3 months of transplant, they should go back to some restriction of diet. And the diet should be always sterile, as you said very correctly. They should not eat any raw food.
Yes, thank you, sir. Professor Mire, there is a question for you. Whether the branched-chain amino acid pills are good or the food sources are better than this?
Well,
what are the food sources for this?
Food is always better, but we do not have branched-chain amino acid isolated in food. We have dairy that has majority of its amino acid, or not even majority, 50% of their amino acids coming from branched-chain amino acid, but they come with all the other nutrients, all the other amino acids and some phosphorus and potassium. So what I usually do is I just give a diet, not looking into branched-chain amino acid. As I said, I give a restrictive diet, let's say 0.8, and then the rest that I want to add up to make sure that the patient doesn't get malnourished, I add those from supplemental sources of branched-chain amino acid, either their pills or their powders. I try to make sure that if the company that I'm buying from, the pills can be crushed and I don't have a powder form, I would ask if I can crush them, because I want to make sure that I have less pills for the patient to take. So what I do is I would say have the powder, mix it with your food, so because it doesn't have taste or smell, it just has a white color. So if you mix it with food, they don't feel like yet another medication that they're taking. So unfortunately, we do not have food sources that are only branched-chain amino acid. We have, as I said earlier in my lecture, dairy that are higher in branched-chain amino acid compared to other protein sources, but they do come with phosphorus and potassium. So if you drain, like strained yogurt, cottage cheese, if these are used, there's a better choices of protein because they are low in phosphorus, potassium, rich in branched-chain amino acid, but you cannot guarantee that you're only giving branched-chain. So I don't look at them as, you know what, if I give you cottage cheese, then I'm just giving you branched-chain. I look at it as just for protein within the protein recommendations, and then add on top the branched-chain that I wish from supplemental sources, either powder or pill.
Okay. Yes. So, sir, what is the carbohydrate recommendation for the patient with diabetes with very high GRBS and CKD patient on alternative day dialysis? Because if you give low carbohydrate energy is spared from protein and fat, as you mentioned in
the question is 40% of CKD patients are of diabetes. Now, when they are not having any CKD, you have caloric restriction and normal proteins. But once they develop CKD, there are two things happen in these patients. Because of their poor GFR, the excretion of the drugs, oral diabetic drugs which they are taking, that also is delayed. Their metabolism of insulin is also reduced, so there's more insulin available for the same amount of what they are taking. And in fact, these patients are developing recurrent hypoglycemias when they are taking their anti-diabetic drugs. So the policy in CKD patient is improve their calories, ask them to eat more energy, maintain their anti-diabetic drugs rather than reducing it, maintain their insulin if required rather than reducing it, but increase their calories from 1200, 1400, 1600 to 2000. So that with the same amount of oral anti-diabetics or insulin, they will be able to take more calories, which will be protein sparing, and you will be able to restrict proteins in these patients to prevent progression of kidney disease. So the question always comes up with diabetic patients. Okay, what do we do with carbohydrates? No, you maintain them. You give them calories with carbohydrates and fats and continue their anti-diabetic therapy. Only those patients who are very high blood sugars on pre-dialysis patients who are not controlled, there only you have to reduce carbohydrates and give more, don't give them high glycemic index food. Give them low glycemic index food, which has got more fiber, ask them to eat more frequently and control the diabetes. But if you start restricting calories in this patient, they will become marasmic, their muscle mass will come down, and their lean body mass will come down.
Okay. Yeah, got it. Dr. Saha, do you prescribe egg whites for low potassium and phosphorus along with the oral?
Yeah, very good drug. Now, the question of phosphorus, as I said at the outset, when you give animal proteins and vegetable proteins, there are a lot of vegetable proteins also where phosphorus is high, but it has got more phytate content. So when you take it orally, less phosphorus is absorbed. While in animal proteins, the phytates are low, so more phosphorus is absorbed from the GI tract. Now, phosphorus is always linked with your proteins. When a patient and with his food, what he likes, suppose he likes animal proteins, you allow him to take egg white, allow him to take chicken, fish, everything, and the phosphorus is going up. At that time, don't stop it, because that is the first intention of any nutritional advice is to take home food. And if the phosphorus goes up, then you start treating it with phosphorus binders. So you don't restrict any protein for the sake of phosphorus. There are certain diets which are very high in phosphorus and says no proteins, like your processed food or colas. So you ask the patient, don't take processed food, don't take colas, but any animal proteins or vegetable proteins, even if it is a phosphorus, you please take it. If your phosphorus level goes up, we'll give you Sevlamar.
So with respect to the phosphorus, there should not be any differentiation between the veg and...
Phosphorus comes large quantity from your preserved food, processed food, and colas. So you stop your patient from taking processed food, colas, and preserved food. If they take fresh food, whether it is animal protein or vegetable proteins, you will be able to manage the phosphorus quite well.
Thank you, sir. Professor Mire, the last question for you. I know the time is running out. So what is the diet you will prescribe for high urine creatine level, but there is a normal blood serum creatine and blood urea levels?
High urea, high blood urea?
High urine creatine, but there is a normal serum creatinine and blood urea levels.
So it would be also high albumin in the urine, you mean?
Yeah. A few of the cases.
I have a feeling this is more like a nephrotic syndrome, as if, I don't know, it looks like it.
That means these patients' kidneys are working well. And whatever extra protein he is taking, kidney is taking it out. Because creatinine is normal, urea is normal.
Yeah.
You should not worry. Kidney is handling it well. Only if there is a very strong history, genetic in the family of CKD, this patient, you can ask them, restrict your proteins to normal person. Don't take high protein diet. But if creatinine is normal, urea is normal, and if he's washing out more creatinine, so most probably he's taking more proteins.
Yes.
This we see in patients who go to gymnasium and take protein supplements. You look at their urine, they will have very high creatinine. And that is the indicator the kidneys are working well. They are handling the excess of proteins. I would not worry. So
I thank you for the answer. And when we take only what we need, the 0.8 gram per kilo, the body uses it sparingly for muscle mass production. And when you're taking it extra, it just takes it out. So even for, why I wanted to give the nephrotic example, for example, nephrotic, they're losing protein into the urine. And if you give them high protein, they lose more. And if you give them 0.8, they keep it and improve their health. So when you are taking what you need, you use it sparingly. So in that case, as a doctor said, it seems we agree too much today, 0.8 gram per kilo but it is very important to say standard body weight, not ideal. Ideal is too low.
Yeah, thank you, ma'am. So we talk a lot on the kidney disease today and its preventive and treatment management, everything. But sir, do you like to give some brief message to our elite audience on the day of World Kidney Day?
So the message is very clear. Every patient on CKD, not on dialysis and dialysis, not only control of blood pressure, it's not available, unstable. Yeah, it is not only about treating hypertension or treating diabetes. It is more about treating malnutrition in this patient. Encourage patients to eat kitchen feed or a home feed as much as possible, because that is economically possible to the patient. And if you are keeping a good diary, and you need not do anything, you ask only relative to take a good diary of the weight and this and that other things, what we have gone through in the lecture. And if you just go through it, if the weight is coming down or albumin is dropping, then just take little more interest in these patients, refer them to a nutritionist, ask them to follow up the patient every month. And as Dr. Mire said correctly, 1 hour every month for a year, that will change sudden outlook of nutrition of the patient. Because most of the time, patients follow the advice given by the dietitian, not by the dietitian, but by the neighbor. And they continue to follow all wrong advices which they were taking not when they were not on dialysis, and when they come on dialysis, they will refuse to take high protein diet. So that you have to counsel them. And now you are on dialysis, your whole diet changes, and now you don't look at your creatinine, you look at your albumin. And higher the creatinine, better is the dialysis, better is the nutrition on dialysis. While lower the albumin, lower the cholesterol is a poor marker of your health on dialysis. So this has to be told by a nutritionist to the patient, because he's going to spend more time on eating habits and eat different foods with the patient. We are going to give medicines. It is your job to spend time and emphasize to the patient, eat well, eat well, eat well. And at the right time, give the nutrition supplements and help the patient.
Thank you, sir. Professor Mire, the brief message from your end to our elite audience. I just like to include from your side, if you are able to say more on the preventive aspects, what are the risk factors we should look for to prevent the kidney diseases?
Obesity and diabetes, attack those. And renal failure, most of it goes away. Very few cases of renal failure. I don't think any one of us would have talked so much about dialysis if obesity and diabetes were treated. So obesity, metabolic syndrome, diabetes, and the easiest way out, maintain healthy weight. You maintain healthy weight, You eat a variety of diet with moderation, you know, and these two words are basically the first two words I got in the first course of nutrition in my bachelor degree. That was far, far long ago. If anyone remembers these two words, then they're good. Healthy weight, variety of diet with moderation. You prevent obesity, you prevent insulin resistance, you prevent metabolic syndrome, diabetes, and kidney failure. I mean, as the doctor said, around 40 to 50% of the cases are only from diabetes. And we're not talking about hypertension and all the other lifestyle-related diseases. Very few are actually kidney-related. So, prevention.
So, if I take it correctly, so elderly patient with diabetes and hypertension, with obesity, we should do the regular screening.
Yes.
Yeah.
And screening. Yeah. Screening them, not waiting for them to come to the doctor with urinary output decrease, with some uremia symptoms, with some malaise. Screen them when they're obese and they're diabetic. Try to address aggressively their treatment, but also screen for microalbuminuria, because definitely helping patients early on is far better than helping them when they're already late. It's not cost effective. And anyways, you know that you're just delaying the end stage situation, but you're not treating.
And adding to what you said, the symptoms of kidney disease come when kidneys have already failed 80%. So if you wait for the symptoms to come to screen these patients, you're lost the game. It is any patient who is obese, who is diabetic, who is hypertensive, who has a stroke, who has got a metabolic syndrome, must do their urine routine every year, do their EGFR every year. They should avoid painkiller drugs. They should avoid Ayurvedic drugs. They should avoid herbal medicines. They must stop smoking. They must not restrict their alcohol intake and healthy lifestyle and exercise, 30 minutes of exercise. And now what the campaign is going on in our nephrology society in India, ek chamach kam. You reduce 1 spoon of salt, 1 spoon of oil, and 1 spoon of sugar every day from your diet. And that will go a long way in preventing major diseases.
Thank you, sir. Thank you, ma'am, for joining us from all the way from UAE and giving us a lot of insight.
My pleasure.
Thanks for that.
Thank you.
Thank you all, audience.